Thanks so much, Ben, and thank you to all the presenters before me. Next slide, please. And next slide. So I'm going to follow Ben's management of hospitalized patients, and now we're going to transition to what do we do with medications that patients received during their hospital stay, and do they need to continue these medications once they're being discharged from hospital? And so going back to Eddie's patient who was initially discharged home from the emergency department and unfortunately represented with hypoxia requiring admission to hospital, he's now been admitted for a few days and received some therapies in hospital such that he's ready to be discharged home. And as you're preparing his discharge summary and going through the EMR, you see that there's a number of medications that were used to treat him, and we need to decide on whether or not he's going to continue these at home. Next slide, please. And so I'll follow along Ben's line of thought here in terms of discussing dexamethasone, remdesivir, tocilizumab, anticoagulants, and recombinant antibodies, specifically sotrovimab. Next slide, please. So our patient was admitted to hospital due to hypoxia and requiring supplemental oxygen. And so as you heard, we treat for a maximum of 10 days for patients when they're in hospital. And when they are being discharged from hospital, there are two ways that this could be managed. Next, please. And what happens with patients who are being discharged home without supplemental oxygen is that their dexamethasone stops once they're discharged from hospital. Next, please. But there are some patients who end up being discharged home on supplemental oxygen. And we were doing this a lot, of course, when we had a number of patients being admitted to hospital with COVID-19. And frankly, we needed beds. And so we were using this as a way to facilitate discharge home if they were on low flow rates of oxygen, such as 2 to 3 liters per minute. And some patients, when they do go home, you may consider extending their treatment course of dexamethasone to complete that 10 days. Alternatively, we have seen a lot of patients diagnosed with cryptogenic organizing pneumonia who've had COVID-19 pneumonia. And management for this is typically high-dose steroids such as prednisone. And what we often did was stop their dexamethasone and transition them to high-dose prednisone in conjunction with a respirologist in consultation for follow-up. Next slide, please. So as Ben mentioned, remdesivir is typically given for 5 days in hospital, and it is only used either in the pre-hospitalization setting or the hospitalized setting and not post-discharge. So if a patient has only received 3 or 4 days of remdesivir, it would stop at the time of discharge from hospital. Next slide. And tocilizumab, as we learned, and same with Barry, both of these are given in hospital. There is no evidence to continue these therapies post-discharge. Tocilizumab is a single dose, whereas Barry is given for up to 14 days, but again, only during hospital admission and not post-discharge. Next slide, please. So anticoagulants has certainly gained a lot of attention in COVID-19 therapies. Low molecular weight heparin, as we heard, is the standard of care for moderately ill hospitalized patients. And so these are patients that are on nasal prongs, so low flow oxygen requirements. And the advantage for them is receiving therapeutic dose anticoagulation, and it reduces risk of progression to ICU level care. What we know is that the maximum dosing period for therapeutic anticoagulation is up to 14 days during the acute illness only. And this is something that would not be continued after hospital discharge unless there's another reason to continue it, such as the patient developed a DVT or PE, or, for example, if they developed atrial fibrillation or were on anticoagulants for atrial fibrillation. So really, we don't continue therapeutic anticoagulation post-discharge unless there's another indication to do so. Next slide, please. Now, some of you may have heard about the studies that are either ongoing or completed that have looked at patients who have been discharged from hospital after treatment of COVID infection. There's a study called the Active-4C trial, which is led out of the United States, and it's comparing apixaban 2.5 milligrams twice daily to placebo for 30 days in patients that were admitted for at least 2 days. And this is an ongoing study, but quite frankly, their recruitment is a bit slow, so we're not entirely sure if it will be completed. But short of that, there is another trial that was published in December in the Lancet called the Michelle trial. And this is a study that was done in Brazil in 14 centers, and it included 320 participants who had all been admitted to hospital for COVID-19. And patients were either randomized to rivaroxaban 10 milligrams daily or to no anticoagulant for 35 days. And they were stratified based on the improved risk score as well as an elevated D-dimer. Now, they had a primary composite outcome, which included a lot of things that are not intuitive to us. So it included things like symptomatic VTE, so symptomatic DVT and PE, but also asymptomatic DVT and PE. And so that meant that patients were getting screening ultrasounds and CT scans of their chest to evaluate for DVT and PE, respectively. They also looked at all-cause mortality, as well as arterial thrombotic events. And of course, because it's an anticoagulation study, the safety factor that they looked at was major bleeding. What they saw in this study was that while there was a significant reduction in the composite outcome, what I would caution you to do is really evaluate your patient on an individual basis. I don't think that we can safely say that a composite outcome that includes asymptomatic screening VTE done by CT scan and ultrasound is necessarily significant enough that we're going to use this for all of our patients discharged from hospital. My personal approach for this is if patients have had previous VTE, especially in a provoked setting, such as after surgery or hospitalization, then those are patients that I would consider higher risk for VTE, and I may prescribe them DVT prophylaxis post-discharge. Again, for a few weeks, 4 weeks is a reasonable strategy. Next slide, please. And then I bring up this slide with recombinant antibodies related to sotrovimab. So we learned from several of our speakers previous to me that sotrovimab is really meant to be used for patients pre-hospitalization. In my hospital where I work in Ottawa, we have had some patients receive this in hospital. And really it's patients who are admitted for reasons other than their COVID infection. And then they develop COVID in hospital. And so we have been giving patients sotrovimab in hospital, but again, this would be done only during hospitalization and not post-discharge. So that's the reason that I mention it here. Next slide, please. So before we move on to questions, I just want to go to the next slide and just highlight one of the things that we have for Thrombosis Canada. So when we had availability of Paxlovid, as you heard from all of us this evening, there are many drug-to-drug interactions that need to be considered, including the direct oral anticoagulants. And so this is a statement that we put out saying that this needs to be done with caution if you're going to use Paxlovid in patients that were receiving DOACs. And I'd invite you to also see our guide on drug-drug interactions, which you can see on the next slide, please. Perfect.